Welcome to the Aesthetic Society's Roundtable. We're going to talk about an important topic, breast implant-associated ALCL. We're going to talk about diagnosis and treatment that's relevant for the clinician. Starting off with what's new. Well, since 2016, breast implant-associated ALCL has been recognized as the fourth form of anaplastic large cell lymphoma. What are the current numbers? Worldwide, 885 cases in the U.S., 307. There have been 33 reported deaths worldwide and 13 in the United States. Those numbers have changed since this slide in February. I know of 2 more cases, so the numbers are always changing. Now, one of the interesting things is we've always heard that this does not occur in Asian patients, but now we know there are some cases. Bill?
Yeah, I think there's definitely an HLA predilection, I think, for the disease, but for a long time there were not cases in Asian patients, but I think there are certainly a few documented cases now. Again, it's evolving day to day, really.
Yeah, there have been a couple cases in South Korea, I think a case in Indonesia. So there's some genetics involved in it, but we can no longer say we haven't seen cases in Asian patients. Now, another new thing is the FDA has proposed a black box warning for breast implants about breast implant-associated ALCL. Steve, you think that's a good idea?
I do. I think that education is key, and I think that the more awareness that there is about this very important topic, the better off everyone is going to be. So I think it comes down to, even at the time of the consultation, a vigorous discussion regarding this and other things I think is mandatory. And I think up until now, not everyone has been as educated and as aware. So I think it's nothing but a good thing.
Yeah, Bill and you and I have been working with a collaborative community on this. What's your take?
Well, I mean, I think awareness is great, but the issue I have with just a universal box warning is that there's not been a case of smooth implants, pure smooth only in ALCL. So, and especially in the United States, where smooth constitutes almost the vast majority of implants done, especially now that there's been implants removed from the market, I'm not sure that's necessarily is appropriate. I think it sometimes creates an element of fear in something that just we've not even seen yet. So I think it's fine for textured implants. I support that, but I don't see that it's appropriate for smooth implants.
Yeah, I agree with that. I think it could cause unnecessary fear in patients, because especially when you see the FDA that report there are smooth cases, but those are cases and were never pure smooth cases ever been found.
No, I think it's worth saying again, because there's a lot of different people having ideas about smooth implants. There's still, when we know the whole history of that particular patient's case, no case of pure smooth implant developing BIA ALCL. And I'm always mystified at the resistance to accepting that fact right now, because even in the texture devices, there's just profound differences in the incidence of BIA ALCL between textures. And I think there's a real possibility that the environment just is not right in a smooth implant to create ALCL. And the idea, I agree, with a broad stroke of the brush, but just claiming all implants are at risk of BIA ALCL, we actually have zero evidence for that to be true as of now.
Yeah, and there's a good scientific reason why we're not seeing it in smooth implants, and maybe at some point we might, but again, it's going to be incredibly rare. I mean, the textured cases are incredibly rare, and now that, the other thing now that we've taken, all the Microtexture implants have been removed from the market. So the question is now, the incidence in the Microtexture implants is exceedingly low, like 1 to 80,000, 1 to 100,000. That's not very high at all.
Right. And remembering that if it's 1 in 80 or 90,000 of getting BIA ALCL, that's not of dying of BIA ALCL. That's that. And if you remember that the risk of dying from a cosmetic breast surgery is 1 in 72,000, it just puts in perspective how rare it would be with one of those textures, not BioCell, but one of the other textures, of dying from this lymphoma.
Yeah, so now I thought what we would do is walk through a case, because we want to talk about the practical. Patient comes in with this. Now, I didn't introduce my panel members because they don't need introductions. Bill Adams, Brad Calabrese. We also have joining us virtually is Steve Sigala from Scottsdale. I'm going to show a patient of mine who had breast implant-associated ALCL so we can walk through the process from the first phone call that the patient gives to the office is how we get these patients diagnosed. So this patient is in her early 40s. I did a breast augmentation 6 years prior with a Microtexture gel implant. She called my office on Monday morning and said the previous Thursday she thought she had pulled a muscle. It just felt tight. So, well, I worked out kind of hard, maybe I did something. But then over the weekend, she noticed her breast was swollen. And we had sent letters out to all of our patients about the risk of breast implant-associated ALCL, and any change in their breast, we'd ask them to call. So she calls my office, and my patient coordinator takes the call. And where do you go from there from when these calls come in? Brad?
Well, I think first and foremost is that it has to start with your front office in knowing what these calls may be coming in, and these are the calls that you actually make sure you get to your clinical nurse to give the right answer and information, because you want to see this particular patient. This is not a patient that you can wait down the line and see them. You need to see them right away. They already know something about this because you already sent them a letter, right? So it's in their mind is why they're calling. And so that's where we start with, is educating our front office on these types of phone calls. And what was the letter you sent out? When I sent my letter, I made sure all my front office people read the letter that I sent, so they would have that information. So I think it starts with just that, is making sure the frontline people take that phone call and get it to your clinical people to make sure they get on the schedule.
Yeah, prior to the era of ALCL, if a patient called and said, oh, I had my surgery 6 years ago, they might have just blown that off as, well, we'll get you in a month. So I think educating your staff is really important, that they don't put that patient on months from now. And having the nurse talk to them and know what to do ahead of time. We did, when we sent letters out to our patients, we put a script next to the phone so they knew what questions to ask and what to look for and who we needed to get in right away. So this patient, then they make an appointment for her to see. I saw her the next day. So a patient comes in with a swollen breast, Steve. What's the first thing you do?
I mean, obviously, physical examination, history, how did it start? Was there any trauma associated with it? And kind of ruling out more of an infectious nature based on story. And then on examination, you're looking at the breast, it's unilateral, it's clearly larger than the other side. It's not necessarily erythematous, such as an infection, but clearly the volume of the affected side is different. So I think also important is a full, axillary palpation, just to kind of do your own due diligence to see if there's any adenopathy there present. I think that's important part of the examination, and then take it from there. But I think just noticing swelling unilateral, given the story, we certainly have to be highly attuned to the possibility of anaplastic large cell lymphoma.
Yeah, so Bill, you have a patient with a swollen breast and a textured implant. That has to be ALCL, doesn't it?
Well, usually it's not. The vast majority of those they're related to bacteria, which actually there is a continuum of all these things. We believe all of the ALCL and non-ALCL are related to bacteria, but the vast majority of late stromas are non-ALCL, but usually the treatment's the same thing and the diagnostic algorithm is the same thing. So in that patient, once you've done everything that Brad and Steve have talked about, that you want to do an ultrasound. So if you have that in your office, it makes it really easy, or if you have you can send them to a radiology department if you don't, but you want to do an ultrasound, you want to see if there's a late stroma. If there's a late stroma, you want to draw off the fluid and you want to send it for two things, CD30 and then cytology. And so those allow you to rule out well, put it this way, you want to try to diagnose that before you take the patient to the operating room. So if it comes back that they have something consistent with ALCL, that's important information, because you're going to do some other things probably before you operate on the patient, including getting a medical oncology consultation and probably a PET scan. But if it comes back negative, then my management of that is typically I talk to the patient. My experience is that textured implants, they have a late stroma, you can put them in antibiotics. It typically might resolve for a period of time, but they always recur. And then I end up having to do the same thing, which I would do for ALCL, which is a total capsulectomy to cure the patient.
Yeah, so I think the important thing is to get the patient diagnosed, and the next step is an ultrasound. So we have ultrasound in our office. This is the ultrasound that I did on her, which showed a large fluid collection around her implant. One of the advantages of having ultrasound in your office is you can make this diagnosis pretty quickly. So I aspirated the fluid, and this is the fluid that was aspirated. How much fluid do you need to get this diagnosis, Brad?
Well, we'd like 50 cc's. It would be great. They can do it with less, and so I wouldn't, because sometimes they don't have as much. But the truth is, if it's ALCL, generally there's plenty of fluid. These are usually large fluid pockets. When you get 5 or 10 cc's around an early developing capsular contracture, and I do think it can be hard to tell the difference between a capsular contracture sometimes, or a double capsule, and a true seroma. That's why the ultrasound is so important. So we'd like 50 cc's. I definitely think you should talk to the person taking the radiologist taking that fluid out if they're doing it. We try to do it in our office if we can, and we are able to send it all off, because if they don't get enough, that's a real problem. So.
Yeah, and you see a lot where patients will call panicked because they had an MRI for something else and they saw 5 cc's of fluid in the pocket, and the patients will want this aspirated. What do you tell those patients, Steve?
You know, I think you have to take everything seriously, but you know, there's always going to be some degree of fluid around an implant, and it doesn't necessarily mean they have ALCL. I think once again, bringing them back in, formal evaluation, history, etc. If it's something that is easily accessible, there's nothing wrong with tapping it, obviously. But I think I wouldn't get overly excited about a 5 cc periprosthetic fluid.
Yeah, it also, once you get the fluid out, if you're doing it or the radiologist doing it, we do see a lot where the radiologist didn't send it off for the right thing. So you got to make sure you're sending them to someone who knows what they're doing. We have a pathologist that we send all of ours to that automatically knows what to do with these. Now, in contrast, this is a benign seroma. Looking at the difference between this fluid, I had actually done that like the week before. Very clear fluid versus this kind of cloudy. When I aspirated the fluid from this patient, my heart sank because I knew that's what it was. So sure enough, her pathology came back, breast implant associated ALCL in the seroma. So next step.
Well, you can't forget this either. The most important is you need to then stage them, because now you know they have BIA ALCL, and it does matter whether it's at the fusion-only state, whether it's through the capsule, if there's any mass associated with it, if there's any metastasis. So as Bill mentioned, a PET or PET CT scan or MRI to stage it, to know what you're dealing with before ever you go to the operating room. And then you need to get either to a tertiary center or at least have a team so that you have a surgical and or medical oncologist to work you through this program, because they need a real treatment for cancer.
Yeah, should these be done, Steve, at a tertiary center, or can we do them ourselves in our private practice?
I think in private practice is okay, provided that you have an associated medical oncologist that you trust, radiologist that you trust, kind of a team, just like we have with our breast cancer disease. And so I think as long as you're working in the confines of a true team, I think it's reasonable for this not to be done necessarily at tertiary care centers. But if there's any question, obviously I think referral to a larger center is appropriate.
Yeah, and I don't think the buckets are like private practice and say an academic institution, because it depends. Sometimes like you'll have some people in the academic institution that do like 2 capsulectomies a year versus like someone like Brad that's doing 500 or 1,000 revision breast cases. So it's just that you do want to have a team, you want to have a connection with other specialists that person would need to see, but it's really the experience of the practice that you really want to make sure you do confirm. So.
Yeah, the surgery itself doesn't take any, if you do a lot of capsulectomies, but you just have to, the most important thing is to remove the entire capsule.
Yeah.
Yeah, and if it's BIA ALCL, it needs to be an en-bloc resection, which means that you kind of need to get a negative margin. That means it needs to have normal tissue around it. So it's kind of margin at all cost, right? And so I think I would do this case at a hospital instead of my own surgery center, because there's a bigger chance of a pneumothorax in this type of a case, and I wouldn't be prepared for that, or resection of whatever it is, because for certain, that's why this is classified in a TNM classification, is because it acts like a solid tumor, whereas lymphomas under Ann Arbor, they don't follow typical tumor progression. This one does, and the predictor of a bad outcome is not getting negative margins. So getting negative margins is by far the most important aspect of getting cure.
Is it different, Bill, if there's a mass rather than just a seroma?
Well, it's different just because the staging of the tumor will be different, but really the outcomes and treatments are similar as long as the mass is not penetrating through the capsule. But it's really a staging thing. But still, you want to remove the entire capsule en bloc, as Brad said. And then, depending on the final pathology, that way that may be all the patient needs, or if they have, there are a few of these patients who have had advanced disease. Luckily, again, like the good thing about this whole thing is that it's a new entity, but these are incredibly responsive to number one, basically 100% of patients that we know about to date who have had disease confined to the capsule have been cured. Basically just with the capsulectomy. And even patients who have advanced disease sometimes can respond very well to brentuximab, and so they actually have options, and so that's really a staging thing that we just have to see. But yeah, taking the capsule out, not leaving any capsule behind is the key.
And even though 70 to 80% of these present as a seroma, of those, 30% have a mass, 30% or more have a mass, and about 15% have lymph node involvement. So it's just to reiterate that the staging is extremely important. And I personally, if it's maybe just, I see nothing else besides the fluid, I may be more likely to take out the capsule. If I have a mass that's exceeding into the chest wall or any place else, then I'm for certain not going to be doing that operation. I'm going to be passing that on to somebody because they may expect to do a bigger resection.
And again, that's why, if you have, that's why you want to diagnose this prior to going to the operating room, because you're going to get some other studies, like say, like PET scan, and maybe also an MRI, and a medical oncologist to consult with the patient, and that may guide you, and you may see something in one of those exams. Say, okay, there's extension of this somewhere, and then it's a different deal.
Yeah, I've been contacted by some patient advocates who said they had patients who had an abnormal aspiration of fluid and went back to their explant expert plastic surgeon and said, well, it doesn't really make any difference because it's the same operation anyway. Well, it makes a big difference. It's like knowing whether there are nodes involved, knowing whether there's a mass, knowing to look for where the mass is, it makes a big difference. So these patients, you send them to an oncologist. The NCCN guidelines recommend laboratory exams, looking to make sure their liver's okay in case they need adjuvant treatment, any other medical optimization they may need. A PET scan's probably the most important thing. And my patient's PET scan just showed uptake in the fluid around the implant, nowhere else, which is a good thing. So the NCCN guidelines, once they're diagnosed, treatment is removal of the implant. Staging is solid tumor staging, and it just, whether it's just in the fluid, the capsule, outside of the capsule, and that makes a difference on the treatment. So treatment, we talked about en bloc, capsulectomy. Adjuvant treatment is not always, unless it's outside of the capsule, there's external masses. So this is my patient's specimen. This was done at Washington University. Marissa Tenenbaum did her surgery. And you can see that it's marked. It's really important that the margins be marked and clear. And fortunately, for her, it was a stage 1A, fluid-only ALCL. And there's 2 points to be made on that. Number one, I had an educated patient. She knew she had something in her breast that changed, and she needed to let us know, because if you looked at it, it wasn't terribly swollen, but there was a change in her breast. And the next thing was getting a diagnosis early and getting her treatment. I mean, that's what we owe our patients, is early diagnosis on this. So an educated patient, your staff being educated, and then getting these patients. From the time she had her first symptom till she had this surgery was 2 weeks. So that's makes a difference for these patients, and I think it's important. So I have a few other questions I want to ask you about. So should we still be using textured implants? Steve, you still use them?
I've converted 99.999% to smooth. I will occasionally use a textured implant if in a very rare situation where the patient really wants one and or the benefit of that device outweighs the relative risk of getting ALCL. And after a long educated discussion and the patient is aware, I still I will use a texture device. I just did one 2 weeks ago, and it was the first time I had done one in a long time. But I think given the right situation with education, I still will use it, albeit significantly less than prior.
Bill?
Yeah, I mean, I personally don't use a lot of texture. It's usually a patient that requests it, or if somebody has a severely constricted breast, I'm considering using an anatomic implant for that. But just my practice, I'm using primarily smooth implants. However, what I would say is if somebody wants to use a texture implant, or the patient wants to, the surgeon should be able to do that and have confidence that using proper techniques, they're going to really minimize the risk. And secondly, all the implants that have the highest incidence, because they're a Microtexture, are now not even available. Right. So the current textured implants have exceedingly low numbers of cases and incidences. So again, you got to make sure you're comparing apples to apples. So I think texture can still be used. It's just not a big part of my practice personally.
Brad?
Yeah, I use very little to no texture anymore. I just slowly progressed to really being smooth. And I think I would just say it's because when I started using smooth, we have better devices now. We have more cohesive, optimally filled devices that deliver a better result than we had with the earlier generations of smooth devices. I have the ability to use like P4HB or something to support my breast when I need to, especially in revisional cases. And then I have fat grafting to create a teardrop shaped, anatomical shape with a round implant. So I have a lot more tools than I used to have. And I think with that, it has allowed me to step away from texture and most of the time get a result that's as good or better than the textured.
Yeah, I stopped using textured implants in 2016. There's still times where I think there's a benefit. I think as Bill said, I think it should be a choice that a patient and a surgeon can make together. I do think the surgeons using them should be board certified plastic surgeons. I think they should be appropriately trained on the use of textured implants. I think there should be a special consent form for those patients. And the patients need to agree to follow up closely as well.
I remember a while back, I was with Bill and with Non-Diva, and Anand made a comment. He said, well, it looks like BIA ALCL is a textured implant event. And I said, so let me ask you this. If I could take a textured implant and place it into the pocket and not get any bacteria on it at all, is it still a textured implant event? And he said, no, actually it's not. It's a bacteria event. And it's just the delivery is through a textured device. And so I think in the end, if you're going to use textured devices, the reason I say that is that you're going to especially want to adhere to the 14-point plan and to things such as that, because the bacteria are much higher levels in textured implants. And so if you're going to want to use a texture, you're really imperative that you use the best technique with that.
Yeah, and I don't think you can completely eliminate the risk of bacteria in a pocket, because we're going into a dirty field anyway, because the biome of the breast may make a difference. That leads to another question is, I've had 2 ALCL cases, one from 2002, one from 6 years, a case that I just showed you. Am I a terrible surgeon?
No, not at all. There's a lot of factors, and we know that obviously texture is a carrier for this a certain type of bacteria, but also there's a genetic component. There's different virulence of bacteria, not only even amongst hospitals in a city, but certainly across the world. So the point is, you're an excellent surgeon, Pat. We all know that. But just there can be circumstances that are beyond your control. So I think that it's a misconception that like if you got a case of ALCL, that means you're a bad surgeon. That's not it at all. It's just, but we're all human, and we all are trying to be self-critical and do things better every day. And so this is just, as Brad said, there are certain techniques that we all adhere to and do whenever we're using a prosthetic device, and that's just good practice.
Yeah, when I had my first case, which was a few years ago, was a revision reconstruction from 2002. Well, that was at a point where we could not use betadine. Our hospital I worked at, I used Cantrex solution because that's all that we had at that point in time. And we really didn't have a 14-point plan then. That was a breast reconstruction patient, so we didn't need nipple shields. But this last case, I used betadine irrigation, we used nipple shields. I didn't use a funnel, but didn't use drains. And you think, boy, you do everything right, and it can still happen. And I think sometimes, a lot of people say, oh, I've never had a case. The other thing that I've seen is I would not have known my first case had the surgeon who treated her not told me. So, it's easy to say I've never had a case. You may not know. You may have had a case and never actually knew that it happened.
Yeah, but it's so rare. I mean, there's 800 cases in 60 years of breast implants, and there's, 35 to 50,000 breast implants worldwide, breast implant patients worldwide, probably more than that. So, yeah, it's a very rare thing. So, of course, like most surgeons are not going to have a case.
Last question, will there ever be a smooth case?
I say it's possible, but unlikely.
Yeah, I think that that there, probably at some point there will be a smooth only case, but it's not the end of the world either. Again, it's an explainable thing. We understand why that is, and it's just science. That's all it is.
Steve, think we'll ever see a smooth case?
I sure hope not. I really hope not. I would have to say it's incredibly unlikely. I think it's highly unlikely.
Yeah, I asked this question for the aesthetic meeting at home. I asked Roy DeVita, Peter Lennox, and Anand Diva. And Anand and Roy thinks there could be at some point. Peter did not. I lean on it, there probably will not be, but never say never. Who would have thought we'd be talking about this 20 years ago?
Yeah, and I think the take home from that for me is that smooth devices, as it relates to ALCL, are very, very safe devices. And we haven't even seen one yet. And we're talking about, will we ever see one? I think I have a whole new perspective as we've gone through COVID-19 of what incidence is and what's prevalence of what happens, right? And we talk a lot about this, but it's so rare as we think about it compared to how quickly we can see something take over and stuff. So I say, not, because I think that we would have seen it by now.
Yeah, and even with the highest risk device, there's still a 99.9% chance that patients with textured implants will not ever develop this. Steve?
I think all of our thresholds are so much higher nowadays, and we operate just with a whole different modus operandi. We're so concerned with bacteria from a technical standpoint that it consumes us during surgery. I think far more so as a whole than it did 15 years ago. And so I think because I think we are all better surgeons in 2020 than we were 15 years ago, I think that's going to lessen the likelihood of this progressing and happening with other types of devices. I think technically we are way better than we used to be for the most part.
Yeah, and I think bacteria have changed. And when I was a general surgery resident in the mid 80s, no such thing as a staph infection, methicillin-resistant staph. Now, they have special rooms for patients. So things have changed over the years, and things may change into something else in the future. So one last practical point to tell our viewers on ALCL. Bill, start with you. Anything else you want people to know?
I think patients should know awareness is key. That is the key to everything. You want to educate your patients, make sure they're aware of what to watch out for. And if you're able to do that, we know that we can treat these patients expeditiously and extremely successfully.
Yeah, I think that in the United States, one of our biggest concerns and biggest efforts through the ALCL task force with the Aesthetic Society is awareness, because patients being out there and possibly having swelling in their breasts and not knowing about it, or family practice doctors seeing those patients and not understanding, is a real challenge, because we've got to catch them early. So sending letters to patients and having articles in other journals that inform them and educate about the early signs of ALCL is extremely important if we're going to get a good cure rate on these.
Steve?
Yeah. Don't blow anything off. If anything changes from here on in, give us a call. Don't blow anything off. I think that's so important, because if this can be caught in a timely fashion, it's a completely curative disease.
Yeah, and I think educating non-plastic surgeons about this. I did an educational program for non-plastic surgeons on ALCL that the Aesthetic Society sponsored with Mark Jewell, and 80% of non-plastic surgeons have never heard of breast implant-associated ALCL. So you see some delay in diagnosis as they may go to their gynecologist, they may send them to a breast surgeon, or they get a mammogram to look at it rather than sending it from an ultrasound. So I think if, as a society or as plastic surgeons, we can go out and educate our colleagues, the gynecologists, the primary care doctors, the nurse practitioners, PAs in your area that are evaluating women, let them know if they see something to call us. There's a radiologist in our area that if he sees a late seroma, he calls me about it and we'll send the patient to see me so we can make sure the patients get appropriately treated. Thank you for joining us. Thank you to the Aesthetic Society and Allergan for sponsoring this roundtable on a very important topic.